Microsatellite stable, unresectable patient, has had OX-based therapy, has had ERI-based therapy, has had the appropriate biologics depending on their characterization at that point, is still an excellent performance status 0 to 1. It's 2 years later or 18 months later since you first met. And they're unresectable, as I said, for metastatic disease. Can you guys describe a little bit the distinction, what you think about rechallenge versus reintroduction? The way I like to think of it, are the chess pieces still on the board and you can move them again, or are they not? Paul, why don't you define for me what you think of a drug that's still on the board that you've played once?
Well, in general, so patients who've had adequate exposure to irinotecan, fluoropyrimidine, oxaliplatin, and the antibodies, at that I consider refractory and would almost never find a good reason to go back to using them.
Let's say they only had 4 months of oxaliplatin and you stopped it after a nice partial response.
Oh, well, I would have already reintroduced it in
done
first
that
line
earlier.
before I would have ever switched to irinotecan.
So it's already been played.
Exactly. So
okay, anybody else have a different?
I agree, because it's just a conceptual. Here we are really in refractory patients.
Right.
So patients in which we think that everything we had as a strategy of first line and second line worked and then failed. Yeah. So this is a patient in which the candidate is either for experimental therapy or for TAS-102 or for regorafenib. Then the question will be, what of the 3 things I will do?
Right. But I'm seeing a distinction here about, you know, did you progress on it or have you already replayed it? And I'm seeing people using another VEGF when they've already progressed on a VEGF, or you guys use a lot of EGF again. If they had front line, then you did VEGF second line.
My first option in a patient that did, let's say, in first line left side tumor, anti-GFR, and responded. And then he did the second line with other chemo with bevacizumab, and then responded. And now he's really in progression. And I think that first and second line have done whatever they could have done for the patient. And actually the patient has a metastatic disease that is more than 1.5 years, because this magic number tells you that these patients are surviving with therapies. And these are the patients that have the most likely the possibility to have a benefit by either TAS-102 or regorafenib.
But so this is
and
where
then
I want to
will be my first
this.
option.
Yeah. So you know, Paul's got this strategy of reintroducing right away. I tend to not. I hold it because I'm not sure of any survival benefit there. And so the EGFR too, it's emerging, but not survival benefit. Whereas I've got 2 medicines for whatever, you know, TAS and Rego have survival benefit. And why we, you know, should there be a strategy of using those drugs before rechallenge?
The question is the immediate reintroduction, as you're suggesting, Paulo. We do this later, and I think we can also do this later. We should not forget that this patient was not progressing on the oxaliplatin. This can be used later, whenever.
So either immediate rechallenge, but it's still
and just to push back on your evidence-based medicine comment earlier, though, I mean, we actually have data, at least some data, not randomized data, obviously, for reintroduction, early reintroduction. We have very little to say, you know, oxaliplatin after fourth-line therapy.
Emery de Gramont, the group, has exactly the same information. They have data from immediate reintroduction and from later, and even better rates from later reintroduction in these series. So that's
but you know, in terms of toxicity, for example.
But these are experiences too. They're not really tight trials, but it legitimizes doing it. Everybody's saying that. It's what I'm sort of drilling down on is when and how.
So your question is mostly about the timing. Do we do it when we think we should per Optimox or per Optimiri, or can we do it later? And so let's say Optimox, Optimiri, you can actually find evidence for that. For the later lines, you know, it is possible. I mean, we all see these patients that have come from, you know, as referrals. They've went through 4 months of, let's say, FOLFOX, and then, you know, went on maintenance for 6 months or 10 months, and then when they progressed, they went on FOLFIRI. So the question when they come to your clinic after 2 lines of therapy is, should we take them back to FOLFOX? This is where I agree with John. I think that the evidence lacks significant evidence. There may be some, but the evidence
is the same, Tony.
No, hold on.
Early or later?
No. But this is, you skipped a therapy. This is not directly. So this is FOLFOX, FOLFIRI, and you still think oxaliplatin hasn't been reintroduced. The evidence actually, significant evidence, lacks. There is some evidence, and clinically we know that there are some patients. But I would actually move this to the 5th line rather than to to the third
This
line.
is to be discussed. I say
Right.
later. I say
Well,
later.
I mean, I wouldn't say it's to
there's
be
no
discussed.
right one place to put it.
It needs to be studied. I don't think the
Well, we
discussion.
Because I have
Fortunato.
2 lines with TAS 102 and regorafenib that we can discuss, hours, what is better to do before, what are the differences in terms of toxicity, in terms of
We're not going to spend
perception of
hours, but
toxicity.
we're going to discuss
But
that.
beside that, the concept is that when I finish all the potential, the first 2 lines, I have these 2 options that are, especially if the patient survived so long to first and second line, are maybe the patients that will respond to a sequential treatment with these 2 drugs. Because now we have evidence that if a patient responds to regorafenib, has higher chances of responding to TAS 102 and vice versa in this patient population. So maybe we have 2
Which
lines.
is probably
before-
a biology that
Yeah.
we're finding here too.
Yeah, no, absolutely.
So-
And there is data, it's retrospective, from Mayo Clinic, MD Anderson, and USC and others, that essentially when you expose patients to regorafenib, and then you this is before TAS 102 was approved, and you re-challenge them or reintroduce or whatever you want to call it, that you still see some really decent response.
Yeah.
So
I'm
you
old
don't
enough-
lose the benefit from the chemotherapy
Yeah.
after you go through these
I'm
these
old enough to
effective
remember
lines.
being so excited about any new medicine for colorectal cancer, and particularly one with an overall survival advantage. And every time one of my patients does not get these 2 medicines, I feel a little bit like I've not done my job. And so I always try to make sure we're going to use these. And we're, as you all are too, we're phase 1 clinics, and so we throw those options on the table as well. So now we've got reintroduction, we've got 2 drugs with approval and survival, and we've got trials, which is what we're in the business of doing. And so, and we kind of want to get them all in.